Okay, so talking about our respiratory distress patients, we'll talk about these 6 differentials and talk about in general how we assess patients with respiratory distress problems. Again, from the top here, as you walk in, it's probably not a code yet. We want to quickly do some CVO. These patients may have circulatory issues. They quite obviously have ventilation or oxygenation issues. And then some of the emergent urgent interventions in the green areas may need to be provided. If the patient's O2 saturation is lower than expected for him, you want to jump right in there and supplement that with O2. If the patient is wheezing, in all likelihood, bronchodilators, and our choice would be a mix of ipratropium and albuterol, would be the obvious thing to get going there. So there are some things to get started while you continue to investigate and arrive at a differential as to which one or 2 or 3 of these conditions are the main issue. Again, oxygenation, ventilation are our primary focuses here. Most of these folks are okay from a cardiovascular standpoint. Maybe the CHFer or the pneumonia patient that's septic would be the outliers there. But you're going to have to start with the ventilation and oxygenation issues. Number of things in our toolbox. We have PEEP, we have oxygen, we have bronchodilators, either inhaled or injected, and some smooth muscle relaxers. We can add into that. We've got steroids. We can increase or we can decrease preload, and a number of things in our toolbox. And so these respiratory patients can be a little bit complex. And so that's what we're trying to do here, is help you organize your thinking as you manage these. Starts with a good history and physical. History and physical, those two things go together. Obviously a pulse ox, obviously capnography. I can't imagine why you would manage someone in respiratory distress and not use capnography. You can look for ventilation and look at rate, effort, and depth. Look, listen, and feel on the chest. Get on the lung sounds. Lung sounds are probably the most important piece of the assessment that will help you differentiate these patients. Some of these are also cardiac patients. We're probably going to have to attack the respiratory part first, and then you use clues from past history and medications, and you just try to build up this entire picture and work toward your differential. So wheezing comes from a narrowed bronchiole. It's narrowed either due to constriction or obstruction by mucus or obstruction by inflammation or all 3. And that makes wheezing. Loud wheezes means there's lots of air moving through there. Quiet, tight wheezes means there's not much air moving through there. You can see wheezes by looking at the capnography waveform, a shark fin waveform, the westbound shark that we talk about. The shark fin waveform, as opposed to a nice square capnography waveform, the shark fin waveform and the degree that it's sloping can help you quantify how your patient's doing and if they're responding to your treatment. If you see a shark fin and you don't hear wheezes, that patient is extremely tight and it's extremely dangerous. The other thing important to mention about wheezes is that sometimes you can get confused between, is this stridor or is this wheezing? So it's location, location, location. Stridor is loudest over the larynx, over the throat. Obviously an upper airway obstruction. You may be able to hear some stridorous noises in smaller people down low, but if you hear anything musical, you should listen over the throat as well as over the lungs. So don't confuse that. The treatments are different. The issues are different. We need to make sure that what we think is a wheeze is not really stridor. Here's our differential list. We'll go through these one at a time. We'll start with asthma or the wheezing from an allergic reaction. This is bronchial issue. We're trapping the air on these patients. They're hyperinflated. The air can be pulled in, but it can't be forced out. Therefore, PEEP is of no value to these folks. Inhaled bronchodilators are just that. They're inhaled. They have to be inhaled deeply down to the airways, the terminal bronchioles, and not dead space to the major airways up high. And so many times your patient has been using these, and you may give inhaled bronchodilators, and if you don't get any kind of impact, be concerned that your patient's dead spacing and the medicines aren't even getting there by the inhaled route. You might need to switch to the injected route. So steroids are great, except they don't do us any good in the field. I'm not saying we shouldn't start them in the field. I'm just saying that we shouldn't start messing with them before we've done everything else that will actually work in the field. So once you've got your bronchodilators in action and things are getting better, then go ahead and load them up with the steroids that will help them an hour down the road, but don't let that be a distraction. COPD treatment, not all that different from asthma. The COPDers can be either emphysema or chronic bronchitis, usually wheezing, sometimes some crackles. PEEP does help these guys in most cases. Their pulse ox may be a little bit lower than you would expect. So on a good day, some of these pretty bad lung disease patients with pretty severe COPD, they may, on a good day, be running at 92 or 93%. And so it's important to try to determine what is a norm for them and then kind of adjust your O2 therapy. We don't need a non-rebreather mask on all these folks. Having said that, if the pulse ox is under 90, I just get kind of worried and we'll go with a non-rebreather for a short period of time. Another thing you can work with is that if you can use a cannula at 2 or 3 liters for 2 or 3 minutes, you ought to see an increase of 2 or 3 points in that pulse ox. If all they needed was a little bit of bump from oxygen, then that should work. If you're not getting any increase, then you may need to look at either are we ventilating enough, or you may need to go ahead and increase that O2 a little bit. But large amounts of high flow O2 just for everybody doesn't make a great deal of sense, and particularly in the case of these COPDers that run in the low 90s as a norm for them. Another thing to look for with these guys is that they cough all the time. They have a cough every day, and they spit up a little bit of usually white or clear sputum. But if they end up with an infection, then that cough will be worse, and they'll be coughing up a different looking stuff, yellowish, greenish sort of thing. May have a fever or chills. Remember, these guys are constantly in a state of kind of bad pulmonary situation, and so it wouldn't be out of line for them to be pushed over the edge by a little bit of acute bronchitis or pneumonia. And they have weakened alveoli, so a spontaneous pneumo is certainly something to keep in mind. Looking at CHF, we're primarily talking about the left side, left ventricle failing, either from one big MI or multiple MIs, or from ventricular hypertrophy, from chronic hypertension, where that ventricle is pushing against a load all the time. Preload reduction really helps these guys. You can reduce preload by sitting the patient up and giving them nitro. Usually they will sit themselves up for you, so that part's already done. Many of these guys will sleep on 2 or 3 pillows. They may sleep in a recliner, and you may be able to ask them about that if there's been a change in that recently, where usually it's only 1 or 2 pillows and now it's 3 or 4, or they just can't sleep through the night. PEEP will usually help these guys reduce their work of breathing, maybe recruit some additional alveoli that are sitting around not doing much and get them in the mix and helping out. Typically the lung sounds are crackles, although you may hear some wheezes. This is not really a bronchular thing. This is an alveolar thing. But as fluid builds up and issues continue to spiral, then you get some wheezing also. So go ahead and treat the wheezes, but the crackles are what the big problem is. The alveoli are obstructed by fluid because the left ventricle can't pump off enough. So we need to relieve some of the workload for that left ventricle, and that is, by definition, reducing preload. So these are really cardiac patients. They show up as respiratory. The chief complaint is respiratory. You don't walk in the room and say, how you doing? And the patient says, I'm in congestive heart failure. They say, I can't get my breath. But it really is a cardiac problem that's showing up as respiratory. Pneumonia, which is an infection in the lung, pussy fluid that's built up in the lung. You may hear some crackles, some wheezes that may be silent depending on what stage they're in. As that pus develops and fills up the alveoli, you end up with diminished lung sounds, but certainly on the way to that diminished area, it would be normal to hear some wheezes, maybe some crackles. So really it's about history. I mean, it's about a recent illness and a fever and chills and all this sort of thing. But the pneumonia doesn't have to be bilateral, whereas asthma is going to be bilateral, CHF is going to be bilateral. COPD is going to be bilateral. They can have a pneumonia in just one lobe of the lung. So listen carefully, try to add up the whole story. Usually they'll be producing a cough that's got some really nasty, rusty looking, well past green, but yellowish brown, very nasty, thick sputum that they're coughing up, typically of fever, chills, night sweats potentially, and these guys may actually be in septic shock. So where, with asthma and COPD, you probably don't have any blood pressure problems. With CHF, it can be very high, it can be very low. These pneumonia patients, they could be hypotensive, being due to being in uncompensated septic shock. So treat the wheezes, hold the PEEP on these guys, even though it might make some common sense. It's not typically used. Treat the wheezes. What they really need is antibiotics, and they need you to support them and help them if they happen to be a little septic in front of you. Next on the list is a PE, and this is typically assessed in the field based on history. Sometimes these people have a suddenly sedentary lifestyle, a long airplane flight, a long bone fracture in the leg, and they're not as mobile as normal. They may have had some leg pain where the clot developed and then it broke loose and traveled. But typically this is a sudden onset of dyspnea. And if there is chest pain, it's usually pinpoint and pleuritic, worse with a deep breath, and they can show you where it is. This is not your cardiac chest pain that is center of the chest, pressure, heavy squeezing. This is more, can localize it, can point to it with one finger, worse with a deep breath. And the deal here is that it shows up as a respiratory thing, but this is a vascular problem. This is a blood clot on a pulmonary artery or pulmonary arterial. And so that isn't going to change your lung sounds. It's just going to change the perfusion of that lung, change your oxygenation, but it's not going to change your lung sounds. The guy that COPD that wheezes every day is going to wheeze on the day he has his PE. If a person doesn't have any lung disease, their lung sound should be clear. So here this patient is acutely short of breath, looks a little hypoxic, and you listen to the lungs and you hear clear, and you begin checking your stethoscope to see if it's even on or something's wrong, because it surprises you. So when you add the story with normal lung sounds, then a PE is kind of what you're talking about. PEs can cause acute right ventricular failure. A large PE can cause that right ventricle to fail. And they can end up in cardiac arrest. If you remember the list of H's and T's that are causes for cardiac arrest, one of the T's is pulmonary thrombosis, and that is a PE. Last thing on our differential list is hyperventilation, and there's two parts of that. One is due to a psychological cause, and that's going to be really helpful to have the history of the current event. What happened? Was there some emotional trigger? The patient involuntarily began breathing rapidly, and then things gets kind of spiraled out of control. These folks are not crazy. This is not a long-term problem. It will self-correct. I wouldn't necessarily say that to the patient. It's in that, well, worst case, you stop breathing and everything resets. I don't think that helps calm them down. Lung sounds will be normal for that patient. Pulse ox should be normal to maybe even high. The end-tidal CO2 should actually be low initially with these guys because they are breathing off too much carbon dioxide. And so really treatment is all about calming them. And you may be able to use that capnography number as positive feedback. As they slow their breathing, their capnography number raises. And so give them a target of 30 or 35 or something to try to get them in, and remind them that even though they've started to control their breathing and the problem is over, the symptoms will persist for a little bit. But even though it's scary, it's no big deal. On the other hand, hyperventilation due to metabolic causes can be a big deal. Maybe the patient's septic. Maybe they're in diabetic ketoacidosis. Maybe they're experiencing excited delirium or agitated delirium. These patients have a metabolic problem, and they are compensating for it with a respiratory alkalosis. They are breathing rapidly and deeply, so it's not just tachypnea. It's hyperventilation. It's rapid and deep breathing, which helps them create a respiratory alkalosis to balance out their metabolic acidosis. Lung sounds will be normal for the patient. The pulse ox will be normal for the patient. The end-tidal CO2 could be up or could be down depending on where they are in their status of blowing off that acid. But you certainly should measure it And so we do not want to slow the respiratory rate. This looks like a respiratory problem, but it is not. It is a metabolic problem, and this is compensatory. So, general warning here, the last minute or so of this presentation, general warning that patients will do whatever they want to do. They can have more than one of these at a time. They can have chronic COPD and then develop acute CHF. Those guys will both have a PE. They can develop pneumonia. Nobody said this was easy. EMTs treat it all the same. They give it oxygen and transport it. We need to be better than that, dig deeper. We're going to have to decide because our treatment is different for the different differentials. So it's good to recognize patterns, but avoid tunnel vision. Just because you've seen this patient 4 times and it was COPD all 4 times, make sure he's not in failure this time. Make sure he's not having a PE this time, doesn't have any pneumonia going on this time. So recognize patterns, avoid tunnel vision, and that also means be careful that you don't just decide on it being one diagnosis and you can't believe it could be anything else. So jump to a conclusion, recognize a pattern, then spend the rest of the call trying to prove yourself wrong. Treat your patients that way and it will keep them safer. And then cardiac patients often have respiratory problems. Anybody getting a respiratory assessment should get a cardiac assessment and vice versa. The patient's chief complaint may end up being something short of breath or something that is not really their main priority. So takeaways real quick. Get to your differential quickly. Your treatments are different. Oxygen is pretty much across the board. If it wheezes, we're doing bronchodilators, inhaled bronchodilators across the board. But whether to use PEEP or not, whether to reduce preload or not, whether to increase preload or not, these are all different, and they're in different differentials. So you need to get that done. How do you get that done? History and physical. Use them both and do them rapidly. Pulse ox is only part of the picture. Use your capnography. See the ventilation as well as the oxygenation. So that's our thoughts on respiratory distress patients.